It's good to be back here. Hey there, Dr. Dan. How you doing? Hope you're enjoying your vacation. This is my second time going live like this on Instagram, and I got some feedback from the last one where people would like for me to wait 30 seconds to a minute to just let people come on board and just welcome people. We got Jess over here. Jess, good to see you. Oh, I can click on wave, it looks like here. Yeah. All right. Yeah, I'm excited about talking today about value-based care. I want to do a recap with what we talked about last week and then get into it with value-based care today. I'm excited. Sure. I see Gabriella has come on board. Hi, Gabriella. Welcome. I'd like to use this time to just quickly introduce myself. My name is Dr. Faisel Syed. I'm the National Director of Primary Care for ChenMed. ChenMed is a primary care organization focusing on senior care across the country. We're currently in 10 states. Next year, we'll be going into Texas. It'll be our 11th state. Very excited about that. We operate our clinics in a unique model, which is called value-based care. And we'll be talking about value-based care today. I'm so excited that you're here, Gabriella. So let's get started. Again, my name is Dr. Faisel Syed. Today, we're going to be talking about value-based care. What is value-based care? Before I get into talking about value-based care, I'd like to do a quick recap with what I spoke about last week on my Healthcare 101 talk. I'm thinking about doing the Healthcare 101 talk on maybe like a monthly basis, just to sort of get everyone on the same page about where we are in healthcare in general as a country. So to recap quickly from last week, the healthcare in America is a fee-for-service system. So 95% of healthcare in this country operates within a system that is called fee-for-service, meaning that there's a transaction for every encounter with the healthcare system. It's a billing system. It's a transactional system. So for a population of 330 million people, we have for the most medically complex, the most medically complex tend to be people over the age of 65. So people who are over the age of 65 only make up about 15% of the population. We're only talking about 45 million people. And for those 45 million people, we spend over $1 trillion in the fee-for-service system for those people who are over the age of 65. And many of them are the ones who have all the chronic medical conditions. Now, we operate in the value-based care world, and value-based care is fundamentally different than the fee-for-service system. The full risk value-based care model only exists for less than 1% of the entire country. So now, the difference between fee-for-service and value-based care, in value-based care, we look at what the unnecessary medical procedures are, or the waste in the current fee-for-service system. Now, what do I mean about the waste in the current fee-for-service system? So think about, I'd like for you to completely forget about the entire system with the way we practice medicine today. Don't worry about how much it costs to see the doctor or how much it costs to get medications or any of that. That's a $3.5 trillion pile of mess. Focus on things that are unnecessary. And if you had to pick the most unnecessary or the most wasteful part of our entire system, it's unnecessary hospitalizations, starting with unnecessary emergency room visits. Now remember from last time, my pneumonia treatment cost almost $7,000. The same treatment I could have received in the outpatient setting for literally $7 to $10. So it's almost 1,000 times more expensive to get treated for pneumonia in the emergency room setting than it is in the outpatient setting or in the regular clinic setting. So now, value-based care and the type of value-based care we practice exists within Medicare itself. So in the Medicare world. So with Medicare, there's two types of Medicare. There's the straight standardized Medicare, which is what we're all familiar with Medicare supplement plans. And with straight Medicare, 80% of the cost or 80% of the risk is with the government. And then 20% of the risk gets transferred over to the patient. And for that 20% of the risk, insurance companies have Medicare supplement plans A through J that you can sign up for as a patient. And then you can pay, depending on the plan you get, they have plans A through J costing $100 to $200 a month to cover that remaining 20%. And that's with straight Medicare. And that's pretty much the fee-for-service system. That's a fee-for-service model. Then there's Medicare Advantage. And Medicare Advantage is the world that we live in. And now with Medicare Advantage, all the risk gets transferred from the government to private insurance companies. And when all that risk gets transferred to the private insurance companies, the insurance companies then partner with primary care doctors with different levels of risk. So there's three general types of risk in these value-based care arrangements. The first type of risk, generally speaking here, is where there's no downside risk to the primary care doctor. In this type of arrangement, there's only shared savings. The second type of value-based care arrangement is where there's some downside risk to the primary care doctor. Now the primary care doctor's got some skin in the game. And the third type of risk is the full or global risk. This is where most of the healthcare premium gets transferred over to the primary care doctor. And that's the type of value-based care that we practice at ChenMed. So now we have control over most of the healthcare dollar. In the full risk value-based care world, we're not concerned with billing. You see, in the fee-for-service system, the fee-for-service system is concerned about billing and generating revenue. Now, how do we stay profitable in the value-based care world? I already told you last time that out of almost $4 trillion that we spend on healthcare as an entire country, over $1 trillion of that is medically unnecessary. And the leading cause of the medically unnecessary cost is unnecessary hospitalizations, which starts from unnecessary emergency room visits. And the fee-for-service system, half of all medical care in America today is delivered in the emergency room setting. It is one of the most wasteful ways to spend the healthcare dollar. I'd like to pause for a second and see if anyone has any questions up until this point. Okay, very good. So no questions. So now, with the full risk model, with the full risk value-based care model, what is my incentive? What would my incentive be if I'm receiving all the healthcare dollar, and I just told you that the current system is wasteful because of unnecessary emergency room visits? The incentive in the value-based care world is to improve health. You want to prevent that emergency room visit to begin with. What does that mean? That means looking into the causes of the causes. For me, I don't want to wait for someone to be diagnosed with diabetes in the emergency room setting, where they feel lousy, they go to the hospital and they find out their blood sugar is through the roof and they have diabetes. For me, I want to nip that in the bud much sooner. I want to catch them before they even become pre-diabetic. I heard a great interview with our CEO, Chris Chen, this week, and he sort of compared the difference between fee-for-service and value-based care, comparing it to going to the mechanic. and going to the mechanic whenever a problem arises, being fee-for-service. And with value-based care, we're sort of like the warranty. So rather than waiting until, say if we're talking about brakes on a car, rather than waiting for the damage to happen on the brake pads to where the brake pads get grinded down and they start to damage the rotors, and you go to the mechanic and the mechanic having to tell you that, hey, this is a couple $1,000 job where you need to replace the brake pads and the rotors and the calipers. In our world, you come in for your routine checkups and we'll notice that, hey, you know what? This brake pad's a little bit more worn down than the other ones. So let's do something about that. Maybe we're going to have to do something to prevent this from causing damage to the rotors. So then we are able to prevent a couple $1,000 nightmare with the entire brake system being replaced when we can just address the simple brake pad on a regular visit. And that's sort of what we do in the value-based care world. You see, we become profitable when the patients that we're looking after are healthier. In the fee-for-service world, when the emergency rooms and the hospital beds are all full, that's when the fee-for-service system is most successful. That's when the care is most expensive. A lot of billing. You can charge almost whatever you want, and it can be justified because it was in the emergency room or inpatient setting. In the value-based care world, the system does better when fewer patients go to the emergency room or the hospital. Then you can focus on what really matters, which is the doctor-patient relationship. In that world, in the value-based care world, the doctor-patient relationship is sacred. And we stay profitable when our patients are healthier. We do well when our patients get treated with us and we prevent them from going to the emergency room to begin with. So I hope that you understand the fundamental difference today between fee-for-service and value-based care. The incentive in the fee-for-service world is to generate more revenue by billing. The incentive in the value-based care world is to improve health and to reduce unnecessary hospitalizations. And what a great way to practice medicine. I would say it's definitely much more of an ethical way to practice medicine, where doctors and patients work together to improve health. I hope you found this informative. It was a pleasure for me, and I'd like to pause for a moment to see if anyone has any questions. I see Dr. Dan saying to partner with patients to keep them healthy. That's exactly right. Fee-for-service is definitely more of a checkbox system than value-based care. And if you're looking at things like the flu, for example, or the flu vaccination, it's not a matter of just offering patients to get vaccinated against the flu. As a country, less than half of all American adults get vaccinated against the flu because they're just incentivized, the people in the healthcare system are incentivized just to offer the flu vaccine. Well, in our world, we want to make sure that people actually end up getting the flu vaccine. So we're over 70% vaccination rates as an organization with the flu, against the flu, and we have several doctors who are way over 90% with their flu vaccination rate. Well, I hope you found it informative. I really enjoy these talks. I look forward to doing this again next week. You take care now and have a lovely weekend. Bye-bye.